Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is a question review on the drugs and antibodies from our Rheumatology series.
Okay, question 1. A 30-year-old lady presents to her GP with a 6-month history of bilateral small joint tenderness and stiffness, worse in the mornings. X-ray of her hands show osteopenia and erosions at the MRCP joints. Which of the following antibodies is most associated with the onset of extra-articular manifestations in this condition? A. ANA, B. dsDNA, C. CCP, D. rheumatoid factor, E. anti-Rho. So if you want to pause the video now and try to answer it yourself. Reading this clinical scenario, it should jump out to you that this is talking about rheumatoid arthritis. This is a classical history that you would get of a young female patient who's presenting with a few months history of bilateral small onset joint pain and tenderness. It has given you even more hints of giving you some of her X-ray findings of her hands, which are osteopenia and erosions at the MRCP joints, which are consistent with the diagnosis of rheumatoid. If you recall from our rheumatoid arthritis lecture, you would immediately be thinking about a potential 2 options as part of the choices in here. One being rheumatoid factor and the other one being CCP. Now, this needs a little bit more knowledge of you. If you recall, you will remember that CCP is the most specific amongst those two, arthritis, and it also is the one that's associated with the onset of extra-articular manifestation in this condition. Therefore, the correct option is option C. Just to recap, option A and option B are 2 of the most common antibodies in systemic lupus erythematosus. Please click here if you want to hear more about systemic lupus erythematosus as your revision. And option E, anti-Rho, is one of the antibodies that we discussed during our talk on Sjögren syndrome. If you want to hear more about Sjögren syndrome, please click here. Okay, question 2. A 60-year-old lady presents with a 3 months history of difficulty swallowing and tightening of skin over the hands. On examination, the IMT1 doctor notices that she has microstomia as well as red spots over her face and chest. Which of the following antibodies is most associated with this condition? A. ANA, B. dsDNA, C. rheumatoid factor, D. anti-SCL7T, E. anticentromere. So, reading through this case, again, this is quite a classic presentation of scleroderma. You've got somebody who is a middle-aged lady who's presenting with what some of you might remember as CREST syndrome, which is calcinosis, Raynaud's phenomenon, and esophageal dysmotility, as well as telangiectasia and sclerodactyly. This doesn't tell you anything about those symptoms and signs such as Raynaud's phenomenon, but it definitely gives you enough information to be thinking about systemic sclerosis. Now, if you remember from our systemic sclerosis lecture, the 2 antibodies that are associated and are most specific to this condition are option D, which is anti-SCL7T, and option E, which is anticentromere. The difference between the 2 is the different type of antibody is associated with different types of systemic sclerosis. If you recall, you have 2 types of systemic sclerosis, limited and also diffuse, and your limited option is correlated with anticentromere antibody, and your diffuse option is correlating with anti-SL70 antibody. Now, you might ask how you can differentiate on this case, whether this is limited or diffuse, and the answer is going to be given you by the examination findings that has been picked up by the IMT doctor. So she has got microstomia as well as spots over her face and chest, and the tightening of the skin is over her hands. Therefore, this is going to make this the limited version, and therefore anticentromere is going to be the correct option. Question 3. A 40-year-old lady of Afro-Caribbean origin presents with a 6-month history of fatigue and cutaneous rash over her cheeks. She is found to have an AKI stage 3 on her admission blood test. A subsequent renal biopsy shows evidence of membranoproliferative glomerulonephritis. Given the likely diagnosis, which of the following blood tests is not associated with this condition? Options are A. Anti-Ro, B. ANA, C. dsDNA, D. Anti-Smith, and E. Anti-Jo1. So hopefully by reading the vignette, you have gathered that this is talking about a case of systemic lupus erythematosus. It's given you quite a few hints, which is quite classic of MRCP exam, to be hinting you and giving you small tips to point you towards a right diagnosis. So in here, you've got a young lady of Afro-Caribbean origin who's coming in with fatigue and a cutaneous rash over her cheeks, so suggestive of the classic butterfly rash. She has got renal involvement in the form of an AKI, and she has gone and had a kidney biopsy that has shown the commonest type of lupus nephritis. So if you remember from our video on systemic lupus erythematosus, all of these antibodies, other than one of them, are associated with systemic lupus. And the one that is not associated is going to be option E, or anti-Jo1. You would remember from that video we discussed that the latest American College of Rheumatology guideline actually doesn't allow you to diagnose anyone with a true form of systemic lupus erythematosus in the absence of positive ANA. And anti-dsDNA and anti-Smith are two of the most specific antibodies in systemic lupus erythematosus, and anti-Ro is very frequently also one of the antibodies that are found positive in a blood panel of someone with lupus. The other point was to remind you that anti-Ro and anti-La are two of the antibodies that are most specific to Sjogren syndrome. Question 4. Mother brings her neonate to a newborn screening. The pediatrician notices a heart rate of 70 beats per minute, and a subsequent ECG shows evidence of first-degree heart block. Which of the following antibodies is most likely to be present in the mother? A. Anti-Ro, B. Anti-La, C. Anticentromere, D. Anti-Smith, E. Anti-Jo1. So hopefully you have picked up on the fact that the heart rate of 70 beats per minute is very low for a neonate, even though obviously it's quite normal for an adult. And this is clearly trying to hint at a potential passage of antibody from mother to neonate. And if you remember, we did mention that, especially when we were talking about Sjogren syndrome, that mothers who are anti-Ro positive have quite a high risk of passing that through their placenta to the baby. Therefore, anti-Ro is the correct option in here. Just to recap about the rest of them, anticentromere is associated with the limited form of systemic sclerosis. If you want to hear more in details about systemic sclerosis, please click here. Anti-Smith is associated with systemic lupus erythematosus, and anti-Jo1 is what's associated with the case of myositis. Question 5. A 70-year-old lady presents with 1 month's history of difficulty climbing the stairs and 1 stone of unintentional weight loss. On examination, there is evidence of proximal muscle wasting and weakness and a rash over her eyelids. Given the likely diagnosis, which of the following antibodies is most specific to this condition? A. Anti-Ro, B. Anti-Jo1, C. Anti-MI2, D. Anti-Smith, E. Anti-URMP. So hopefully you have gathered that this vignette is trying to talk to you about somebody with a potential diagnosis of dermatomyositis. This is a diagnosis that goes quite nicely with the case. You've got an elderly lady with 1 stone of weight loss and also difficulty climbing the stairs, suggestive of some muscle involvement. You have examined her and you have picked up that she's got proximal muscle wasting and weakness, and you also have picked up a heliotrope rash over her eyelids. From your revision, you would remember that the most specific antibody to this condition is actually option C, which is anti-MI2. To recap amongst the rest, anti-Rho is associated with Sjögren syndrome, and you will remember from our previous question that it's the antibody that's associated with neonatal heart block and bradycardia. Anti-Jo1 is the most specific antibody to polymyositis. This is clearly not correct in here because she has got skin involvement with her rash. If you want to hear more about polymyositis, please click here. Anti-Smith antibody is one of the antibodies that's associated with systemic lupus erythematosus. And finally, anti-URMP is the antibody that's most associated with mixed connective tissue disease. Question 6. A 70-year-old lady presents with a 1 month history of difficulty climbing the stairs and 1 stone of unintentional weight loss. On examination, there is evidence of proximal muscle wasting and weakness and a rash over her eyelids. A CT scan identifies a mass in her pelvis concerning for ovarian malignancy. Given the likely diagnosis, which of the following antibodies is most specific to this condition? A. Anti-TIF1 gamma, B. Anti-Jo1, C. Anti-MI2, D. Anti-CCP, E. Anti-URMP. The clinical vignette in here is quite similar to the previous question, and hopefully you have picked up that it's giving you more information about some of her other investigations, which is the CT scan. Hopefully you've picked up about the fact that this is still talking about dermatomyositis, and as you remember from our talk on dermatomyositis, in patients who are getting diagnosed for the first time with this condition, it's very important to do a malignancy screen. And basically you need to be treating this condition almost like a paraneoplastic syndrome. So quite correctly, this lady has had a CT scan of her abdomen, and that has revealed a mass concerning for ovarian malignancy. Now, those of you who have listened to our video on dermatomyositis would recall that the most specific antibody in dermatomyositis that's associated with malignancies is option A, which is the anti-TIF1 gamma. Just for the sake of recap, amongst the rest of the options, so anti-Jo1 is what I mentioned earlier, which is a specific antibody in the case of polymyositis. Anti-MI2 is correct in that it is the most specific in the dermatomyositis. However, if you read the question correctly, the question is actually asking you what is the most specific antibody to this condition. And by that condition, hopefully you have picked up that this is a dermatomyositis secondary to a malignancy, which as a result of that, TIF1 gamma would be more appropriate than anti-MI2. Anti-CCP is quite irrelevant in here, and that is, as you know, the most specific antibody in rheumatoid arthritis. If you want a recap of rheumatoid arthritis, please click here. And finally, anti-URMP is the most specific antibody in mixed connective tissue disease. Question 7. A 30-year-old lady presents to the acute medical take with a 2-day history of swelling of the left calf. An ultrasound Doppler scan identifies a DVT in her left calf, and on taking further history, she reveals 2 previous miscarriages. She also has been found to have a net-like rash over her thighs. Which of the following blood test is least associated with this condition? So this is quite a classic history of somebody that hopefully has rang alarm bells for you of being positive for antiphospholipid syndrome. It's not an uncommon condition that gets tested in MRCP. They can either ask you as part of an antibody panel, which is what it is at the moment, or it could potentially come up in your PACES examination as part of an Station 5. And therefore, it would be very important when you're faced with potentially someone presenting with DVT or a PE, you really try to think about what's causing that DVT or PE. That would be thinking about, potential malignancies, especially if you're dealing with somebody who is an older patient. And in younger patients, especially females of childbearing age, it would be very important to ask about previous miscarriages. Reason being that unless you specifically ask about previous miscarriages, you would be treating the case as a sort of a standard uncomplicated DVT, which is not the case in here. So going back to the options, you've got A, lupus anticoagulant, B, anticardiolipin, C, beta-2 glycoprotein, D, raised APTT, E, anti-Smith. And if you recall correctly, antiphospholipid syndromes are associated with 3 distinct antibodies, and those 3 are your options A, B, and C, which are lupus anticoagulant, anticardiolipin, and also beta-2 glycoprotein. If you're having a clot in your body, it's not uncommon to have raised APTT as a result of that, which by diagnosis of exclusion, even if you're unsure about what anti-Smith is, would leave option E or anti-Smith as the least associated with this condition. Just for recap, anti-Smith is an antibody that's associated with systemic lupus erythematosus. Question 8. A 60-year-old man presents with a 3-month history of difficulty climbing the stairs and fatigue. On examination, he is unable to sit to stand test unaided. His ESR is noted to be 120. He is commenced on 50 mg of prednisolone once daily, with symptoms noted to be almost completely resolving within a week. Which of the following antibodies is associated with this condition? A, anti-CCP, B, ANA, C, anti-SCL7T, D, ANCA, E, no antibody is associated with this condition. So this is giving you a classical history of someone presenting with the diagnosis of PMR or polymyalgia rheumatica. And what's sort of giving it away, other than the fact that the specific about the history, such as difficulty climbing the stairs and fatigue, and also being unable to do a sit-to-stand test, and the raised inflammatory marker, is that his symptoms have completely resolved after only 1 week of having a low dose of steroid. And therefore, that should hopefully guide you towards the diagnosis of PMR rather than any other autoimmune conditions. And those of you who have listened to our PMR lecture, you would remember that it is actually not associated with any antibody at all. All the other antibodies are for other conditions. Just to recap, anti-CCP is the most specific antibody in rheumatoid arthritis. ANA is the most sensitive antibody in the case of systemic lupus erythematosus. Anti-SCL7T is the most specific antibody in the case of diffuse systemic sclerosis. And if you want to hear about that and the differences between the diffuse and the limited versions, please click here. And finally, ANCA is the most specific antibody in the case of vasculitis. Question 9. A 40-year-old man presents with a 3-month history of fatigue and new onset purpuric rash over his ankles and feet. He is hemodynamically stable. On examination, you note reduced sensation over the lateral aspect of his left leg. A urine dipstick shows 3+ of blood and 2+ of protein. On further questioning, he reveals intermittent hemoptysis over the same period of time. Which of the following antibodies is most associated with the likely diagnosis? Options are A, P-ANCA against MPO, B, C-ANCA against PR3, C, ANA, D, rheumatoid factor, and E, anti-Jo1. So hopefully by reading this vignette, you have enough suspicion that you're most likely dealing with a case of vasculitis in here. This is a middle-aged man who's presenting with purpuric rash and also proteinuria and hematuria and reduced sensation over the lateral part of his leg, concerning for a potential mononeuritis multiplex. They've also mentioned that he's got hemoptysis over this time. So really putting all of this together, you really need to be thinking about a potential case of vasculitis. Now, the most likely diagnosis in here, if you recall from our video on GPA, previously known as Wegener syndrome, is actually going to be GPA. And the most specific antibody in that is going to be option B, which is C-ANCA against PR3. Importantly, you need to make sure that you don't mix option A and B together. Option A, which is the P-ANCA against MPO, is actually the most specific antibody in the case of EGPA or Churg-Strauss syndrome. Option C, as we discussed previously, is the most sensitive antibody in the case of systemic lupus erythematosus. Rheumatoid factor is quite irrelevant in here again. So this is one of the antibodies that's not even the most specific one, because as you recall, the most specific antibody in rheumatoid arthritis is anti-CCP. But rheumatoid factor is another antibody that is used to help with diagnosis of rheumatoid arthritis. And anti-Jo1, finally, is the antibody that's most specific in the case of polymyositis. And nothing in the history in here actually suggests that this gentleman has got any muscle weakness. So there isn't any reason for you to think about a potential case of myositis in here. Question 10. A 50-year-old man with a background of difficult to treat asthma presents to the medical take with acute shortness of breath and drop in oxygen saturations. He also has difficulty walking and on clinical examination has evidence of peripheral sensory neuropathy in his lower limbs. Blood tests show grossly raised inflammatory markers and an eosinophilia. Given the likely diagnosis, which antibody is most likely to be positive? A, P-ANCA against MPO, B, C-ANCA against PR3, C, ANA, D, rheumatoid factor, and E, anti-Jo1 antibody. If you recall from our lectures on different types of vasculitides, you will remember that this case is hinting quite heavily on the fact that this man has potential diagnosis of EGPA, previously known as Churg-Strauss disease, or eosinophilic granulomatosis with polyangiitis. And that is hopefully obvious to you after reading that he's got difficult to treat asthma and he also has got peripheral blood eosinophilia. Therefore, the most specific antibody to the condition is actually going to be option A, which is P-ANCA against MPO. You will remember from discussing in question 9 that it's really important not to mix option A and B together because it's actually really quite frequently tested in MRCP examinations. Option B, C-ANCA against PR3, is what you would be expecting in the case of GPA, formerly known as Wegener syndrome. ANA is the most sensitive antibody in systemic lupus erythematosus. Rheumatoid factor is again, quite irrelevant in here. It's one of the antibodies in the case of rheumatoid arthritis. And finally, anti-Jo1 antibody is the most specific antibody in the case of polymyositis. And in this case, there is pretty much nothing on the vignette that actually should point you towards a potential diagnosis of polymyositis.
So now it's time for some questions. Question 1. A 30-year-old lady with a history of rheumatoid arthritis treated with methotrexate presents to her GP with a UTI. She is prescribed a short course of antibiotics. 3 days later, she presents to her local hospital with profound lethargy, nausea, and malaise. Blood tests show a pancytopenia. Which of the following antibiotics was she prescribed? So the options are nitrofurantoin, ciprofloxacin, coamoxiclav, trimethoprim, and pivmecillinum. The correct answer in this case is trimethoprim, and this is due to the adverse reaction between trimethoprim and methotrexate. Question 2. A 45-year-old lady with a history of rheumatoid arthritis presents to A&E with acute worsening shortness of breath and a dry cough. She is diagnosed with pneumonitis. She was started on a new treatment for her rheumatoid arthritis 2 weeks ago. Which drug is likely to be the cause of her presentation? So the options are methotrexate, sulfasalazine, hydroxychloroquine, leflunomide, and azathioprine. The correct answer in this case is methotrexate, which can cause a methotrexate pneumonitis in rare cases. Question 3. A 25-year-old lady with rheumatoid arthritis is on methotrexate. She wishes to become pregnant. Which of the following is a safe option for her during pregnancy and breastfeeding? So your options are methotrexate, hydroxychloroquine, leflunomide, ibuprofen, and naproxen. And the correct answer in this case is hydroxychloroquine, which is the only pregnancy-safe medication out of those 5. We will be talking further about ibuprofen and naproxen in a later episode. So now it's time for some questions. Question 1. A 40-year-old lady presents with acute shortness of breath, pulmonary infiltrates, a new AKI with proteinuria, peripheral neuropathy, and a vasculitic rash. She is diagnosed with an ANCA vasculitis and receives induction therapy. 2 days later, she notes new hematuria and suprapubic pain. Which of the following drugs is the most likely cause of her new symptoms? So the options in this case are rituximab, methotrexate, mycophenolate, IV methylprednisolone, or cyclophosphamide. So we have learnt in this particular episode that cyclophosphamide does increase the risk of hemorrhagic cystitis, which is why we give Mesna with this particular drug. So in this case, it's likely that perhaps Mesna was not given and she's now developed hemorrhagic cystitis, which would account for her symptoms. So the correct answer is E, cyclophosphamide. Question 2. What is the mechanism of action of rituximab? Anti-TNF, anti-IL-17, anti-CD20, dihydrofolate reductase inhibitor, or a COX-2 inhibitor? So the correct answer here, if you remember from an earlier slide, is anti-CD20. Just to go through the others, anti-TNF inhibitors include examples such as infliximab and adalimumab. Anti-IL-17 includes secukinumab. Dihydrofolate reductase inhibitor is methotrexate. And COX-2 inhibitors will be discussed in the next episode, but do include drugs such as celecoxib. So now it's time to do some questions on what we've been discussing. So firstly, which of the following is a selective COX-2 inhibitor? So your options are ibuprofen, naproxen, celecoxib, prednisolone, and methotrexate. So the correct answer here, as you'll recall from a previous slide, is celecoxib. Ibuprofen and naproxen are non-selective, prednisolone is a steroid, and methotrexate, as you will recall from a previous episode, is a dihydrofolate reductase inhibitor. Question 2. A 30-year-old lady with SLE receives IVIG. She develops a headache with neck stiffness, photophobia, and fever. A lumbar puncture is performed, which shows normal opening pressures, normal levels of glucose and protein, with no organisms. What is the most likely diagnosis? So your options are viral meningitis, bacterial meningitis, aseptic meningitis, and flare of SLE, and a migraine. So the correct answer here is aseptic meningitis, which you will recall is a rare but known side effect of IVIG. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.